Croft. I'm a psychiatrist in San Antonio. We've been in practice now for 24 years. My background is in OB-GYN and psychiatry, and I trained in the early 70s with Masters and Johnson, so I've been interested in sex for quite some time. Over the last probably 15 years, we've done a number of drug studies on new antidepressant agents and have concentrated on sexuality and antidepressants. But in the process, we've realized that sex has become kind of hot business again. It was hot in the 70s after Masters and Johnson published their stuff, and in fact, many medical schools had departments or sections on human sexuality in the 70s. Those all went away, and many medical schools now have about an hour or two of education in human sexuality for younger folks, and almost no education in the whole topic of sex and aging. So that's what I want to talk about today, sex and aging. And it's a kind of broad topic that covers a lot of territory, because we have aging is different, as all of you know, from what aging was when I grew up. I have to show you, when I lecture, these are the people that pay me money to do various things. We've got 9 drug studies going on, and those are some of the companies that we work for, and some of the companies that speak for my speaking and consulting as well. We're an aging population, all of you know that. The percentage of Americans 65 plus has tripled in the past century. We are a population that has an aging boom, a senior boom, if you will. That's complicated by some other things we'll talk about. 85 plus is the fastest growing age group in our country. Life expectancy, as you know, is increasing. The latest figures from the National Institute of Health probably put it above these figures, 76 and 80. People who are now living can probably be expected to live into their 80s or 90s, maybe older. And the significant thing is this: the baby boomers are aging. The baby boomers, the largest cohort ever born into this country, were born between the years of 46 and 64. During those 18 years, there were 76 million of us Americans born. That's the largest cohort of folks ever born. And that subsequent to the baby boomers, subsequent to the late 60s, there has been a birth dearth. That is, there have been fewer and fewer of us born. The baby boomers, a significant number, something like about 25%, had no children, and another 25% had only one child. So there are less children born to the baby boomers and post-baby boomers, which means that for the first time our population itself is getting older. Now, the significant thing about the baby boomers, and I'm just past the leading edge of the baby boomers are now in their late 30s to their mid-50s. The baby boomers have changed every face of the aging process that we've been through. We can talk about that later if you're interested. But the baby boomers have changed the face, if you will, of aging. Aging is not what it used to be. When I grew up, people 50 were old. Now that I've passed 55, old is getting much, much older now. Most of you know that in 1935, when Social Security was founded, it wasn't by accident that they came upon the age of 62 or 65 as Social Security age. Some had proposed 60 and some had proposed 70. The average life expectancy in 1935 was 61.7 years. Yeah, we'll support you the rest of your life. You ain't going to live very long, but we're going to support you. That's all changed now, and that's part of the Social Security problem that we now see. But as baby boomers age, aging itself changes. Not only have we brought years to life, but the baby boomers are determined to bring life to years. That is, as our life expectancy increases, we want to continue, as baby boomers, to be young and vital. And part of that has to do with sexuality. What is sexuality when we age? What is aging anyhow? What is the significance of 65, and it's not what it used to be? Some of you are familiar with the National Health and Social Life Survey published in JAMA a year or two ago, showed that sexual dysfunction in this country is common. Of the 3,000 plus people surveyed for the National Health and reported having some sort of sexual dysfunction, and that crosses the age span. As we age, there are some significant changes. In females, we find in some women, and not in all, of course, decrease in sexual interest, drive, urgency, and frequency. Now, that's not all women. Some women find as they age, their sexual interest level actually goes up. Some women find that as their partner dies, they then, or as they get divorced, they then find another partner with whom sex becomes much more important than it seemed to be with the first partner because they were raised in a different time. But many women, and many men, as I'll show you, find a decrease in their sexual interest level. From an arousal standpoint, psychologically, it requires more and different types of stimulation than perhaps it did as a young woman. We'll talk about that in just a moment. From a physiologic standpoint, we often find women have decreased lubrication and changes in the vaginal mucosa as you age, and the estrogen effect seems to diminish. The vaginal mucosa seems to get a little more friable, a little less well fed, if you will, by its blood supply, and so there are often tears. Because of the lack of lubrication, there can be pain on penetration that a woman didn't experience premenopausally. Orgasm can take longer to reach, it can be more difficult to achieve, and if it occurs, it can be less intense. And some women find that as they age and especially become postmenopausal, they actually have pain with orgasm. The contractions, especially in the absence of a good estrogen level, can in fact become uncomfortable for some women. And then many women find a change in their satisfaction levels. There's either less satisfaction levels or a lack of satisfaction, especially with penile vaginal intercourse. Many women find that as they age, what they really look forward to is being touched and being caressed and being held, as opposed to just having intercourse. And with males, there are some changes that often occur with aging. A decrease in the sexual urgency and frequency, and therefore the frequency with which sex is engaged in may go down. The guy who in his 20s look forward to sex 5 to 7 days a week may, as he gets into his 60s or 70s, look forward to sex once a week or once every couple of weeks, and that may be perfectly normal. This one's important. More direct stimulation is often required. When a guy is in his teens and early 20s, all he's got to do sometimes is think about sex, and bingo, he's aroused. As a male gets older, the type of stimulation may may be different. There may be a need for more direct physiologic stimulation as opposed to just visual stimulation. There is less pre-ejaculatory secretion. That is, the ejaculate from the Cowper's gland seems to diminish as a man gets older. That, in some men, may make penetration for their female partner more difficult because there isn't the pre-ejaculatory secretion, which is often lubricating. The erections themselves may become less rigid, and there may be more frequent loss of erections during a period of stimulation, and that's a perfectly normal aging phenomenon, not understood as such, but perfectly normal. Orgasm may take longer to achieve, whereas previously many men may have had a problem with too rapid ejaculation. As they age, the problem may be that orgasm may take much longer and may be much more difficult to achieve. It may be less intense, and the ejaculatory volume may be less. There may be a longer refractory period, so that the man who before could have sex twice in one night may now find it a little more difficult to have sex twice in a week, so that the refractory period, that period following orgasmic release during which the man finds it difficult, if not impossible, to achieve another erection, may get much longer. There's a study that was published, what did I just do? Let's see. There was a study called the MMAS, the Massachusetts Male Aging Study. This is a study of about 1,300 male participants from age 40 to 70 looking at sexual functioning. And this is what they found, that approximately 52% of males in this group, now this is males 40 to 70, not just 65 and above, 52% of the males had difficulty with erection. We don't call, by the way, erectile dysfunction impotence anymore. And we don't call it impotence for a pretty good reason. It's not what impotence says, it's what it connotes that is the problem. What exactly is an impotent male? It's not an Arnold Schwarzenegger who can't get an erection when he wants to. When most of us think about an impotent male, we think of an ineffective, ineffectual male who just can't get the job done anymore. And there's a psychological stigma to that. So we changed the term to erectile dysfunction. And even Bob Dole felt a little more comfortable talking about his problem. You notice that moderate and complete account for about 35% of the 52%, about 3/5 of those males. And this is what it looks like. As you get older, you noticed more and more males suffer from erectile dysfunction. But they don't suffer from it in the bottom level. The minimal level stays about the same, from 40 to 70. The level of minimal erectile dysfunction is pretty much the same. But the level of moderate and severe increases significantly as males get older. That's for a number of reasons, not the least of which is a self-fulfilling prophecy. You know, I remember when I was a kid, I would go to old Joe the barber, the guy that had the one light bulb above the barber's chair. And Joe, it seems, could only cut hair or talk. He couldn't do both at the same time. So there was always a room full of guys waiting for their haircuts. And I remember one older fella in the chair with Joe, the barber, telling Joe, you know, Joe, I just can't get the job done with my wife anymore. I didn't quite understand what it was he was talking about, but it stuck. Over all of these years, I still remember him saying that. And so the expectation is that as we get older, it's going to all be gone anyhow. We don't know exactly when, but it's going to be gone at some age. That's not true, by the way, but we believe it is true, and sometimes that affects the way we look at things. I'm going to come back to that in just a minute. As we age, There are known causes of sexual dysfunction, diabetes being the most common one, atherosclerotic cardiovascular disease being another one, chronic pain being a common form of cause of sexual dysfunction in both males and females. Chronic pain from arthritis or from whatever the cause. For that matter, any chronic debilitating disease can be a problem. And this one here, depression, can be a significant cause of sexual dysfunction as we age, as well as sometimes the treatment for depression can be a problem as we get older. The effect of hormonal changes. We talk a lot about the decline in testosterone, and indeed as males age, their testosterone levels go down. We generally think of decreased testosterone resulting in erectile dysfunction. So a lot of the stuff you see, especially if you watch television at 2 o'clock in the morning on the infomercials, aims at increasing that testosterone level to treat erectile dysfunction. What's now known is that decreased testosterone rarely causes erectile dysfunction. It often causes a decrease in sexual drive levels, but it's not necessarily the cause of erectile dysfunction. And then elevation of prolactin levels, which can be due to either a pituitary tumor or, for that matter, can be due to certain medications we use, and that we use fairly commonly in older people. Antipsychotics, some of them increase the prolactin levels. Certain of the serotonergic increasing antidepressants can change prolactin levels. And increase in prolactin causes decrease in sex drive. In females, there can be the effect of decreased estrogen. As women age, we know that their estrogen levels go down, especially postmenopausally and perimenopausally even. Estrogen doesn't necessarily, in the scientific studies, hasn't been linked with decreasing libido or sex drive except indirectly. As it causes more pain on penetration, as it causes more difficulty in that department with lubrication and the like, it can affect sex drive levels. The main culprit as women age is decreased testosterone, we now believe. The studies are showing that women's testosterone level starts to decrease probably in their 30s or 40s in many women. Now, testosterone is generally thought of as the male hormone, but we now know that females have testosterone as well. And as the testosterone level decreases, their sex drive level goes down, as does their sense of well-being. Medications can cause sexual dysfunction, and the most likely culprit of all of them are the serotonin-increasing antidepressants, and those include Prozac and Zoloft and Paxil and Celexa and Effexor. All of those antidepressants, which are wonderful for depression. And remember that one of the symptoms of clinical depression is actually a decrease in sex drive. People stop enjoying things they used to enjoy, but oftentimes the medications we use to treat depression can also change and affect our sexual functioning. But in addition, the tricyclic antidepressants can do it, certain of the benzodiazepine tranquilizers, the antipsychotics, especially the old typical antipsychotics like Mellaril and Thorazine and Stelazine can do it. Some of the blood pressure lowering agents can do it, as well as some of the other new medications, both for our stomach and for other parts of our other organ systems. The point is that when somebody has problems with their sexual drive, you need to look at the medications they're on. And often by changing the medications, you can make a positive effect in their sex drive, and sometimes it doesn't work, and I'll tell you why in just a minute. There's another factor that comes into play called spectatoring, and we'll talk about that in just a minute. Remember also that alcohol interferes negatively with sexual functioning. Now, that's just the opposite of what most people think. Most people think that if you're having trouble enjoying sex, what you got to do is take a few nips. And in fact, low levels of alcohol may decrease inhibitions and in fact make sex seem better. But on the other hand, higher levels of alcohol interfere with sexual functioning. Alcohol is a depressant. It depresses not only mood, not only blood pressure, pulse, and respiration, but also sexual drive levels and sexual interest levels. Remember also that narcotics, especially opioid narcotics, interfere with sexual functioning. They will decrease sexual drive levels as well. There's psychological factors that interfere as we age. Number one is body image, especially for women, also true for men, but especially true for women. Many women, as they age, look at their bodies, their own bodies, in a very negative way and believe that they are no longer sexually attractive. And not only as they look in the mirror, but begin to believe that to their partner, they're no longer sexually attractive as well. Now, they often don't bother to check that out with their partner, and I'll explain why in just a minute, but they make that assumption. Now, if it also happens to be true that the male develops problems with erections, absolutely, positively, and totally unrelated to what's going on with the woman will then often interpret her own negative perception as being true. You see there, you know, it used to be I walked naked in front of my husband and he got an erection. Now, I walk naked everywhere and nothing happens. And the nothing happens is because my body is no longer attractive. And without checking it out, they begin to believe it and begin to confirm it with regard to their partner. Same thing can happen to males, but often males don't care. I mean, in our society, the way the male looks doesn't seem to be as important, at least in fiction and in lore, as what the female looks like. There can be relationship factors that can interfere with sexual functioning as people age. Relationship factors such as, I'll talk some about that in just a moment, but relationship factors often as people get older and spend more time together, and it's probably the latter rather than the former, they find that they bicker with one another more. And as it becomes harder to become turned on, the bickering takes on a bigger part in sexual functioning. People get angry more. And often we find as people age, especially get to be in older age, which I consider probably 75 and above, they find that the most negative parts of their personality seem to become increased. It could just as easy be the most positive parts, but it rarely is. There can be expectations. We all have expectations. Listening to old Joe the barber and his client, most of us believe that at a certain age, a guy's going to lose it anyhow. So that when the guy loses it, he believes that's perfectly normal. The expectation that, well, sex just becomes less and less important as you get older. And therefore, if in fact it does, then we've already grown to expect it. Our children don't believe that as we age, we ought to be sexual beings. Most kids have a hard time thinking that their parents, God forbid, are engaging in that sort of behavior. Masters and Johnson, Masters was an interesting guy. It was said that Masters was one of the few people that could make sex boring. He actually could. But Masters did a study in nursing homes, going into nursing homes and talking to the residents about sex. They found that as they had more sexual activity, whether it was self-stimulation or with other residents, as they had more sexual activity, they actually did better. They felt better, they brightened up, had less depression and so forth. They had to stop the study. You want to guess why? Because the kids moaned and groaned and cavorted and, how dare you talk to my mother or my grandmother about that, and so forth. And many physicians also have negative expectations about sex and aging, such that if a patient says, I remember hearing one of my colleagues talking about a patient, a lady in her 60s, worried about the possibility of contracting genital herpes. And the physician said, come on, honey, you don't have to worry about that. That's not a big deal. And the assumption was not that she couldn't contract it, but she shouldn't be having sex anyhow. I mean, women your age don't do that. And many women, I actually made a videotape for Glaxo Wellcome, teaching physicians how to talk to their patients about sex. And one of the vignettes we put in was a lady in her mid-60s who was on an antidepressant and having sexual dysfunction, who says to her physician, Doc, I know at my age it's silly to be worried about stuff like this, but ... Well, it's not silly. And many physicians, we find, are not comfortable talking at all to their patients about sex, but are certainly not comfortable talking to their older patients about sex. And so nobody talks to older patients. It's hard to go into a bookstore and find a lot of books about sex and aging. You find a lot of books about sex, but very few of them are directed. Now, as the baby boomers age, we're going to find a whole lot more books in the bookstores in years to come, but not right now. And then finally, there's something that we call sexual stumbling blocks. The sexual stumbling blocks, many of you will recognize in yourself because they're common to most of us. Sexual stumbling blocks, I chose that term stumbling blocks not by accident. A stumbling block is like a big rock in the middle of the road. If it's broad daylight and you're not in a big hurry, you walk around it and it's nothing more than a potential impediment. But same rock, same road, middle of the night, getting away from an assailant, if you don't see it there, you can stumble over it and cause great damage. Same for the sexual stumbling blocks, and I'm going to talk about specifically how they relate to aging in just a moment. The first is the effect of our early negative notions about sex. Certain things are bad, dirty, and ugly. Certain things are things nice people do, and certain things are things not nice people do. Certain things are things you do before you get the green light for intercourse, and certain things are things you only do after you get the green light for intercourse. So that certain things, like penile vaginal intercourse in the missionary position, are okay. But other things, like oral sex, or rectal sex, or mutual self-stimulation, are not okay. Or certain things, like having sex in the dark after Jay Leno, is okay, but having sex in the light is not okay. Certain things are things that people can do before they get the green light for intercourse, like necking and petting and caressing and touching and doing all that stuff. But after we get the green light for intercourse, we rename all that stuff. We now call it foreplay. I'll explain that, why it's a problem in just a minute. But those are things you only really do before you get the green light for intercourse, never later. The second is lack of appropriate information about sex, leading to myth and misconception. Women who are sexually aroused are always well lubricated. Not true. But we assume it to be true because we don't know any different. Men are always ready. Guys are always ready, and all they need is just a little push in the right direction and bingo, they're ready. And guys can do it a lot. Guys can always get an erection when they want to, and can always satisfy their partner, and can always last long enough, and so forth and so on. What does sex look like anyhow? And that's part of the lack of appropriate information. The most widely purchased product on pay TV is what? It's what?
Stimulator.
No. No, it's wrestling. But after wrestling, after wrestling, it's actually the explicit video channels. Exactly right. Explicit video channels. It's interesting. I don't know whether it's true or not, but somebody told me that one of the reasons the beta format never took, remember beta came out before VHS, and they were made by two competing companies. Beta was a Sony product, and Beta is actually a much better visual product than VHS. But word had it that Sony was not interested in working with the makers of explicit visual materials. And we don't realize in this country how significant a market that is. However, it's not a very good way to learn about sex. Now, I don't know how many of you have watched explicit video materials on TV. I have, of course, but for professional reasons. But if you watch explicit video materials on TV, you get a view of sex which is not real. I mean, first of all, in explicit visual material, these women are having sex with lots of different guys. No romance involved at all. Doesn't have to be. The guys last forever and ever and ever. One time I was in Philadelphia doing a morning talk show on one of the radio channels. It was a big FM station. We were talking about sex, and one of the guys called in and he said, you probably don't recognize my voice, but many of you would know me if you saw me. This was a porn star, a male porn star. And the host of the show, I couldn't believe he did it, but he said, look, how do you guys last so doggone long? And the guy explained to him, he said, first of all, we do it a lot. But he said, secondly, we have 2 or 3 cameras going on there. And so most of what you see in those things is not time actual. They're cut-ins, so that you'll see the same scene over and over and over again, but it's cut in at different times, so you don't know it, makes it look longer. But secondly, the guy told us, he said, look, if we finish a little too early, we just wait a minute till we're ready to go again, and then they just splice it back in as if it's the same thing. So guys get the idea that sex, that normal guys, like these guys they see on TV, last a long time. Most men don't last that long. And these guys can just do it over and over and over again. They don't. And the other thing is, and I'm going to talk about this in a moment, there is always a pattern in the explicit visual movies to what they do. They always start here and go to here, and they always include the same positions and so forth. Well, most people don't do that, and most people don't look like that. What does orgasm look like? Well, if you watch the explicit visual movies, you know what it looks like. There's a lot of mouth moving, and there's a lot of yelling and screaming, and there's a lot of clawing and stuff like that. Well, most people don't look like that. But if that's their training ground, they assume I must be doing something wrong because my partner don't yell and scream and grab and claw and all that stuff, so I must be doing something wrong. Lack of effective communication and cooperation between the partners. Sex can be the most intimate form of communication that two people who care about one another and love one another can have. And yet for most couples, it is absolutely the least effective type communication they have. I've been married 36 years. If I am sitting at the dinner table in front of my wife, Benet, and I'm eating chicken, and I like ketchup on my chicken, and the ketchup is in front of Benet, and she doesn't pass me the ketchup, I don't think to myself, what the heck did I do wrong? Is this our anniversary that I forgot? Is this her birthday? Did I say something wrong today? Why isn't she passing me the ketchup? Is she hacked off at me? What's wrong? If I've told her once, I've told her 1,000 times. When I eat chicken, I like ketchup. Why isn't she passing me the ketchup? If she really loved me, surely she would pass me the damn ketchup. We don't do that. What we say is, honey, would you pass the ketchup? But isn't it interesting when it comes to sex, we do exactly that. Why is she doing that? Why isn't he doing that? If I've told him once, I've told him 1,000 times, this is what I like. If she really loved me, surely she would know what I liked and do what I liked. Why isn't she doing that? Lack of effective communication and cooperation. The business about body self-image is complicated because people can't communicate with one another about sex, so they never talk about it. And especially people who are now in their 60s and 70s grew up at a time when sexual communication not only wasn't taught, but it wasn't done. The effect of situational factors. If we're angry, if we're upset, if we're anxious, if we're doing sex for the first time in a different way. For example, we see in many widowers who have not had sex except in their whole lifetime, except with one partner. Their partner is now dead. They have mourned an appropriate period of time, and now they're dating again. And they really would like to have sex, except they feel this tremendous guilt. It's not right. I never cheated on my husband or my wife in all of the 50 years we were married. I can't do that now, and so forth. The effect of situational factors. The effect of prior negative experience. If sex is uncomfortable or unpleasant, it's unlikely the next time we're going to want to do it. If sex causes us great emotional distress, the guy who can't get an erection and is embarrassed, the effect of that may occur in his next sexual experience, and it occurs because of this. When we have sexual difficulties, we don't say to ourselves, ain't no big deal. Tomorrow's a new day. Everything's going to be cool tomorrow. The sun will come up tomorrow. Everything will be fine. We don't say that. We look back to a lot of those myths and misconceptions that we learned as a kid, and we say, oh my Lord, I knew someday it was going to all be over with, but not today. I'm too young today. It can't be over with today. And those old myths about what impotence is, for example, becomes prominent. I don't want to be impotent. I want to be a real man, an effective male, and so forth. So from that time forward, henceforth and forevermore, we become a spectator in our mind's eye to our own activity. So the woman who can't reach a climax for the first time in her life or doesn't lubricate because she's getting older begins to worry about it the next time. And if it happens a second time, the pattern gets cemented. So it's like we're watching ourselves in our mind's eye, like we're on camera, watching ourselves perform. We're in the bed doing our shtick, but at the same time we're watching ourselves. And praying, wishing, hoping, begging, pleading, it's gotta work, come on, it's gotta work. And the paradox is, the harder we try, the more anxious we become, the more anxious we become, the harder we try, the more anxious we become. The more anxious we become, the more likely we are to fail. The more likely we fail, the harder we try the next time. And it becomes a vicious cycle. Masters called it spectator anxiety, or fear of performance. So that oftentimes it's the medications or the alcohol that got us in trouble in the first place. We done stopped the medicine now, but the reason the problem keeps going is this fear of performance or spectator anxiety, because we're already into that, worrying about whether it's gonna be okay. So we see often people who are on opiates using too much painkiller who are told, you know, if you just stop that painkiller, sex would be better, but they don't, but even though they stop it, they don't believe it, and so they continue to have problems. Now, what does that have to do with aging? Well, our early negative notions about sex, that only certain things are okay, may be okay when you're young and your partner doesn't need very much stimulation. But as your partner needs more stimulation, if you're not comfortable with being naked in front of your partner, if you're not comfortable with manual or oral stimulation of your partner, if you're not uncomfortable with anything other than penile-vaginal intercourse, that potential stumbling block can become a real impediment to sexual functioning. The lack of information, if we don't know that as a woman ages, she becomes well lubricated, we're likely as males to think, well, I'm not turning her on. She's just not sexual anymore. Or if she can't reach a climax. Or if the guy loses his erection, as we saw, which is often normal, the woman thinks, I'm not sexy enough anymore. and I'm not attractive enough, or he must be having an affair, or whatever. The lack of effective communication and cooperation we've talked about, it becomes even more important as we get older. Certain illnesses may interfere with penile vaginal intercourse, for example, treatment for cervical cancer or the like, so that intercourse is no longer possible. So does that mean the end of sex? Well, maybe, sort of, kinda, because the next one, the effect of situational factors, we've talked about anger and frustration and so forth, but there are other things. We in America have grown to think of sex as occurring in three parts: foreplay, it, and afterplay. Foreplay is called foreplay because it's what you do before you do it. It is penile vaginal intercourse, and afterplay is what you do after it. Most people don't play after it. That leaves two parts: foreplay and it. Now, foreplay is called foreplay because that's what you do to get you ready for it. Now, what if you can't do it? What if the guy can't reach an erection? What if intercourse is prohibited because of some illness, or because of the woman has her vaginal mucosa has thinned out and she gets tears and pain when she has well, what is foreplay? Well, we know that breast and genital touching, they're foreplay. We know that oral sex, well, that's foreplay. Well, what about kissing? Is that foreplay? Well, some kinds of kissing maybe. What about hugging? Is that foreplay? Well, some kinds of hugging maybe. And so what happens is, when we withdraw from intercourse, we often also withdraw from all that foreplay stuff. It makes sense, you know. If you ain't going to build a flame, why stoke the fire? And so what happens to a lot of people is, not only do they stop having intercourse, but they stop touching and stop hugging and stop kissing. I'm going to talk to you about that with regard to Viagra in just a little bit, but it becomes a problem. And many of the patients we see say, you know, doc, I could do without that intercourse stuff, but I sure do miss the hugging and the touching and the kissing and the intimacy and the closeness we used to have. We don't have any of that anymore. And then the spectatoring occurs, as we talked about. Negative experience, losing one's erection as a male or having painful intercourse as a female can interfere. Communicating with our patients or our clients about the problem. We think physicians especially, and those other medical professionals, should ask about sexual functioning as part of routine history taking. Just as we ask, how much do you drink, how much do you smoke, we ought to ask about sexual functioning. And the questions about sexual functioning ought to be, has there been a change in your level of sexual drive or interest? Has there been a change in your ability to become aroused, to reach climax, or your ability to be satisfied by sexual functioning? Now, what's interesting is, we'll talk about it in a minute, a lot of people answer no and then come back and qualify it later on. With illness, medication, or risk factors, we recommend what we call the ubiquity approach that says, you know, many patients who have depression notice that their sexual drive level decreases. I wonder if you've noticed that. Many patients who have diabetes notice that there's a change in their sexual functioning. I wonder if you've noticed that. Some patients who take these medications notice a change in their sexual functioning. I wonder if you've noticed that. Or the other thing you can do is use rating scales. The one we recommend for physicians is called the Sex Questionnaire. ASEC stands for Arizona Sexual Evaluation Test, and it goes on a scale of extremely to absent. Extremely is good, absent's bad. And there are 5 questions. Number 1, how strong is your sex drive? From extremely, that's good, to absent, that's bad. How easily are you aroused or turned on? How easily does your vagina become moist or wet during sex for females, or do you get and keep an erection for males? How easily do you reach climax? And then finally, are your orgasms satisfying? Now, the way you score this is the score of more than 19, that's bad. Any individual score more than 5, that's bad. 3 or more scores more than 4, that's bad. But it really doesn't matter what the score is. What matters is you give permission to patients to ask you about sex if they want to, and they don't have to if they don't want to. And this is a patient score deal rather than a physician score deal. Communicating with patients, the first is what we talked about. The second is general questions with follow-up is appropriate. It's probably not appropriate to ask very detailed questions. Who's on top, who's on the bottom, how often, how long does it take, and all that stuff. Those are intrusive questions. But the general questions, have you found a difference in your ability? That's good. And then if they say yes, you follow them up. And what often happens is patients will answer no to all those questions. No, there's not been a change in my drive level. No, not in my ability to become aroused. No, no change in ability to reach climax. No change in my satisfaction. And then they come back 3 months later for their follow-up visit. And it's like no time's gone by. And they say, you know, Doc, I told you last time there wasn't any. Well, there really was. What it does is it gives permission to patients to talk about sex. Patients don't know if it's okay, especially those who are now in their 60s and 70s because they were raised at a time when it wasn't okay. If a patient tells you, and this is for the physicians or the physician's assistants in the group, if the patient opens up, don't try to hustle through. And often the patient will open up the last 1 minute of an 8-minute visit. As they're walking out the doors, they say, oh, by the way, Doc, you know, I'm having this trouble with erections. What do you do then? Well, you can either rush through it, bad idea, or you say, look, that seems like it's very important, and I know that we need to dedicate a little time to it. So instead of rushing through it now, let's set up a follow-up appointment when you and I can talk about it. Now, what's important, this is to the physicians, what's important is, if you do that, make sure you tell the receptionist or the scheduler to do that. Because here's what often happens. The patient goes out and says, Doc wants to see me for a 15-minute follow-up, and the receptionist says, well, the first opening for that is 1.5 years from today. And what that does is gives the message to the patient, they really didn't think it was all that important. So we recommend to physicians, you go out and you say, look, I want to set up a follow-up with Joe to talk to him for 15 minutes on such and such a day. Not to bore you with it, but the model for sex therapy that we recommend, and there aren't a lot of people doing sex therapy, is called the PLISSIT model. It was developed by a psychologist in Hawaii called Jack Annan back in the 70s. He actually wanted to call it the PISSIT model, but his mentors thought that was a bad idea, so he changed it to PLISSIT. P is permission. We physicians and medical professionals can give patients permission to do things, even older patients. We had one lady who said, Doc, you know, I never did any of that fancy stuff in my first marriage, but I'll do whatever you tell me is okay to do. But what they need is permission from somebody. They can't ask their moms because their mom ain't going to talk to them about it. They didn't do stuff like that, but they will listen to we as medical professionals. LI is limited information. A lot of people just don't have the correct information about sex. I won't say that, never mind. Specific suggestions are suggestions that we can give people to do to correct their problem, especially talking about medications and other treatments I'll mention in a second, or intensive sex therapy. Medications for females. If they're having trouble, especially with pain on intercourse or decreased lubrication or a sense of well-being, hormone replacement therapy is probably important. Testosterone is still somewhat controversial, but probably will get less so over time. There is no testosterone preparation which has been approved for women, but testosterone gel, testosterone ointment and cream can be used. But it has to be used in low quantity, low percentage, so that you don't cause hair growth and lowering of voice and other kinds of problems. There is now been released for males androgel, a testosterone gel, but it is too potent for females. Wellbutrin, we published a study this past May, which got us on Early Morning with Brian Gumbel. None of you probably saw it because nobody watches Early Morning with Brian Gumbel, but we published a study of women with hypoactive sexual desire disorder, HSDD, women with a lack of sexual dreams, fantasies, and so forth, and Wellbutrin, the antidepressant, seemed to help in this study. With regard to males, Viagra is the biggest thing to hit the market in a long time. Viagra works by causing a lengthening of the time which a compound called cyclic GMP is around. Cyclic GMP comes from the breakdown of nitric oxide. Nitrous oxide is laughing gas. Nitric oxide is a smooth muscle relaxant that works through cyclic GMP. Cyclic GMP doesn't last very long and is broken down by something called phosphodiesterase, PDE, especially phosphodiesterase 5. And what Viagra does is blocks the action of PDE5. So as that action is blocked, this cyclic GMP stays around longer and causes the erection to be more likely. There are several Viagra lookalikes now in clinical development by other pharmaceutical companies that work on that don't have the same effect, especially on nitrates. Most of you know, especially the physicians, that if you've got a patient with heart disease who might be taking nitroglycerin or Isodil or one of those nitrates, you cannot use Viagra because nitrates, the nitrate breakdown goes through PDE5, and so if you give a patient who's taken Viagra nitrates, their blood pressure will go through the floor, will drop out, and they can die. There's a dopamine agonist. It was going to be called Uprima. Dopamine is called apomorphine, Uprima, and it was scheduled for release last year. The company pulled it and decided against using it. There's also some apresyline, which was going to be sold under the trade name Vasamax. The company pulled that as well, and that won't be developed. The intraurethral agent was alprostadil, an agent called Muse. It was a little pellet that was put inside the urethra. It worked about 60% of the time. Viagra works actually about 85% of the time in people other than with diabetes and diabetics. It works, severe diabetics, about 50 to 60% of the time. Intracavernosal agents, there were the agents that were shot into the penis by injection. There has now been a gel developed, a Muse type gel that will be put on the penis itself. It's in clinical trials right now, and there are testosterone patches and gels as well. The vacuum device can be used for males. The theory is that blood rushes into a vacuum, so if you can create a vacuum in the penis, the blood rushes in, and then there's this big rubber band looking gizmo that slid off the back of the tube and keeps the blood in the penis. It makes for an okay erection. It's kind of hinged at the back and you can kind of flop it up and down, but it works well enough for erections. And interestingly, a new device for females called the Eros CTD, clitoral treatment device, has just been approved by the FDA, which is the same kind of device for females. Surgery, the use of implants, as well as sex therapy can be used. Just a few slides on the effect of erectile dysfunction. Erectile dysfunction in males can cause depression and self-esteem and self-image and all those problems. Patients with depression are more likely, males with depression are more likely to have erectile dysfunction. So what this slide shows is the higher the level of your depression, the more probable you are to have erectile dysfunction. So here's men with minimum depression and maximal depression, And you notice the maximum guys have a lot more erectile dysfunction. On the other hand, patients with depression or patients with erectile dysfunction are more likely to, patients with erectile dysfunction are more likely to have depression. And this slide shows patients with depression are more likely to have erectile dysfunction or vice versa. Viagra works even in those with depression compared to placebo. And interestingly, this was a study done that showed that as you treat the erectile dysfunction in men who had Hamilton scores of higher than 16, that's the way we measure depression, their Hamilton scores went down to normal. So a lot of times, just by treating their erectile dysfunction, their depression seems to go away, which is kind of interesting. On the other hand, remember that the antidepressants can cause sexual dysfunction. And then finally, it's important to remember if we're treating sexual dysfunction, erectile dysfunction, that we treat both partners in the relationship. I remember when Viagra first came out, this guy who hadn't had anything to do with his wife sexually or physically, really, for 20 some odd years, went to his physician and got the little magic blue pill. And he brought it home, and with a glint in his eye, he says, "Honey, guess what I got? Look at what I got." And she looked at him and to his dismay said, "I don't know what you plan to do with that little blue thing with me, but I ain't going to have nothing to do with it. Go use it on yourself. I don't care what you do with it. But you haven't touched me in 20 years, and you're not going to start now." So that what many women miss is the lack of touching, the lack of closeness, the lack of intimacy, and guys have it all wrong. Guys think it's about not having intercourse. All she needs is a good session of intercourse and she'll be just fine. Well, maybe not so true. So that it's important to remember to treat the partner as well, or at least call them in if you're a physician, if you can. So that having been said, and me babbling on a little too long, I'll now be happy to answer whatever questions you have, and we'll still have time to get to lunch on time. Questions? Yes, ma'am. Yes, ma'am.
And I want to find out, in your experience, how many of the cases that you see in the elderly are psychological versus physiological?
I can't tell you what the exact data is, but my hunch would be it's significantly more psychological than physiological. Now let me qualify that. When I trained with Master and Johnson, we believed that 90% of all sexual problems were not physical, and 10% only were physical. It's now been flipped around, especially with erectile dysfunction, but what we find is that men who have quote-unquote physiological causes of erectile dysfunction often respond to placebo pretty well, which means that it may be that a guy has a low testosterone, but that doesn't have very much at all, if anything, to do with his sexual dysfunction. So it's hard to tell. The point is that it's worth treating whatever it's due, and you can treat it either way. But my hunch is it's probably more not physical, with the exception of those chronic diseases and medications. And as you get older, you're more likely to have atherosclerotic blood vessel disease. You're more likely to have been a smoker. You're more likely to be overweight, and so forth. So those might interfere and be called physiologic, but that may not be the cause of their sexual problems. Did I muddy the water or answer it? Other questions?
Some of the quote natural products that they say are going to improve
Sexual function. Yeah.
I mean, they advertise on TV.
The question had to do with these natural products. You see them on TV, and they have very impressive sounding names. I forgot what it's called, but Maximus and Gigantimus and whatever it is. And the theory is some of them are said increase nitric oxide. We don't know that any of them do that. Some of them are supposed to increase testosterone, but that's rarely the cause of the problems anyhow. And we don't know. I don't know that there have been any studies, but let me tell you another study. I presented a paper in November in Long Beach at the National Association for the Study of Obesity. It was a study that we just completed, a one-year study with certain of the antidepressants that don't cause weight gain. I attended there a program put on by, I think it was Roche. Roche is the manufacturer of Xenical. Xenical is the fat-blocking drug. You know, it blocks the absorption of fat in the GI tract. Their major competitor is not Meridia, the other appetite suppressant drug. Their major competitor is this fat blocker on TV, just like you're talking about. I mean, you see it on TV and you see, God, it's just terrible. I mean, they put this stuff into this beaker full of fat, and man, that stuff gloms together, and I mean, you know, it all goes out your GI tract. So what Roche did is did a study, and it was a very well done study at a major university, and they put these people into the laboratory. They actually spent the night there, ate there, so they could monitor everything they ate and so forth. They gave them a 30% fat diet, and they measured the fat blocker against Xenical. And what they found was, not only did the fat blocker not work as well as Xenical, it did not work, period. Zippo, nada. It did nothing. And yet that stuff sells millions and millions and millions of dollars worth. My hunch is these sexual things are the same. Now, what's important to realize is in the clinical trials with Viagra, about 30% or more of the patients responded to sugar pills, to placebo. So if you're giving people sugar pills named Maximus, they may respond to that too, not because it works, but because it's a placebo effect.
What about women who are at high risk for breast cancer who don't use hormone replacement therapy?
Yeah, and the good news there is that there is now, as you know, in development, a number of other products which may have a lot of the benefits of the hormone replacements that are not hormone replacements. And I think that we're getting to. And we're now learning that, you know, there may be some dietary stuff which could help in that regard without going to medication. But I think it's important to realize and talk to, for patients, to talk to their physicians and physicians to talk to their patients. And that's a perfect example. Many physicians, especially male physicians, will give the hormone replacement without even asking about that other stuff. And people are savvy. Us baby boomers like computers and like the internet. And so we don't listen to our docs very much, and our doctor tells us one thing, well, by God, we'll get on the internet and find out what really is the case. Now, sometimes tragically, it's not really the case on the internet, but oftentimes it is. And so patients are very wise in that regard. But certainly the soy stuff and the tofu stuff may hold some benefit in that regard.
I was going to ask you the same, well, in referral to that, I was going to ask you about soybeans and flaxseed, you know, because I've seen that in articles.
Yeah. I wish I could tell you the science on that. I can't. But I know there's research going on. I think the good news is the only people interested in doing that research would be the federal government. You know, the manufacturers of these natural products have no interest whatsoever in scientifically studying anything. Number one, if they find something good, the FDA is likely to say they're marketing a drug and make them do real research. Or, you know, if they find something bad, it'll hurt them. So they don't need it, so they don't study it. The good news is the National Institutes of Health has now developed a department of complementary or alternative medicine where they're actually studying dietary stuff and nutritional supplements. And I think in years to come we'll find the answers to that.
What goes up must come down. Spinning wheel, got to go round. Talking about your troubles, it's a crying sin. Catch a painted pony, let the spinning wheel